Dr. Bersari, radiological clinical results of 36 patients with Chiari and stingomyelia treated with craniospinal decompression.
I'd like to thank the organizers and Dr. Valentini, even though there are few of us left. This report will outline our experience in recent years on the treatment of Chiari 1 patients with associated syringomyelia. In other words, it's a selected patient group with syrinx that evolves and with a gradually emerging myelopathy. This is the etiology. We defined Chiari 1 as a descent of tonsils below the foramen magnum of more than 5 millimeters. Very often, Chiari diagnosis is made in non-exact situations. Tonsils are triangle-shaped, and CSF spaces at foramen magnum and craniocervical passage is blocked. This is a Chiari 1 patient during surgery. This was a method that I discontinued a long time ago, and I'll tell you why. You can see these ectopic tonsils that have descended down to C2. Well, syringomyelia formed due to the obliteration of CSF flow, whereby a newly created cisterna magna prevents the maintenance of the syringomyelic cavity. Surgery is a rather simple option that doesn't imply any cruent maneuvers on the spinal axis. This is a functional impairment of CSF passage. The extent of this case series is a case series in which we discontinued manipulation of tonsils, syringostomy, Obex plugging, opening of the foramen magnum, and opted for a minimally invasive technique. The main objective was decompressing the foramen magnum to favor normal passage of CSF in a minimally invasive way, so as to create a newly formed cisterna magna. Interestingly, in addition to being minimally invasive, this procedure is effective. I started using this technique in 1996. There's no arachnoid manipulation and no procedure on syringomyelia. So they're relatively modest surgical procedures. Our case series is made up of 36 patients of 36.3 years on average, and diagnosis was and MRI investigation was performed on all patients. Symptoms were mainly craniospinal dissociation. Syringomyelic syndrome was in 68% of cases, craniospinal dissociation in 28% of cases with headache. Many had suffering of the long pathways, and in few cases there was a compression of the brainstem. All these patients had Chiari 1 malformation. Only one patient had basilar invagination, and all of them were well-documented Chiari patients, such as in this one. Syringes were mainly cervical-dorsal, or they could also be dorsal, lower, or holochord. On the right, you can see a holochord syringe. On the left, a dorsal syringe. Our surgical procedure is as follows. We operated on patients in a prone position. We performed a very limited craniectomy measuring 2 centimeters at the occipital level, and we removed C1. Only in 2 cases did we remove C2 for descended tonsils. This is the surgical technique. Here you can see the cranial sector, the atlanto-occipital membrane, and A1. The dura is open, but we always spare the arachnoid. It's a reversed L opening, and duroplasty is performed. Traumatism is very low. We have never had any neurological complications, no mortality. Only in 3 cases we have identified a CSF fistula, and only one of these 3 patients underwent a redo procedure. Results in terms of symptom impact were in 0.5% of cases there was an improvement. I believe that stabilization of symptoms is always a positive result. In all patients, headache disappeared. The symptoms that improved were mainly strength deficits, and sensitive symptoms were those with fewer advantages. In 80.5% of cases, the syrinx was reduced. Not all patients who improved had a reduced syrinx, such as this one, that had a reduction of his holocord syrinx. The cyst was also reduced in this patient, and finally, this is an old case report. In no case was there a post-op increase in cyst size. 80% or so patients had a reduced size of the cyst, and 19.4% of patients had no variation but had a clinical improvement. Only 3 patients got worse. 2 of them had a reduction in the syringomyelic cyst, and in 1 patient the cyst was unburied. The correlation there may be a correlation with the duration of symptoms, which lasted many years, cervicodorsal extension, and associated invagination. The lessons we've learned are that osteodural decompression of the foramen magnum is a simple technique. Arachnoid integrity reduces complication, and duroplasty makes it possible to create a new cisterna magna. The minimally invasive approach overlap other results. I'd like to show this provocative MR. It's a patient I saw 2 days ago. It's a 14-year-old asymptomatic patient with a huge cervical cyst. So I'm wondering what I should do on this patient since he's asymptomatic. Thank you. Why is he asymptomatic? This patient has been managed by his neurologist, who performed MRI imaging studies for parietal headache, and we came to this diagnosis, but he's completely symptom-free. How old is he? 14. Make a flow MRI study. What about his conus? We haven't looked at his conus. Well, take a look. Since he's 14 years old, he may get worse. Would anybody like to add something? You'd perform surgery on him. Me too, but I'd like to investigate a little more first. And what about the surgery technique to be used? Yours is fine. Microphone. I do not have an explanation. Some patients fare badly and they have a small syrinx. Some patients fare well and their syrinx remains stable. I don't know how to demonstrate, how to prove this, how to explain this. But there are only 3 such patients, very few. And I'm actually going to check their flow when I open the foramen magnum to try and see whether there's any obstruction at the level of the foramen magnum. Now, let's leave the floor to Scagnette, extradural section of the filum terminale for the treatment of tethered cord syndrome. Preliminary results. He comes from Florence.
Buonasera a tutti, ringrazio per l'invito.
Thank you very much for a kind invitation.
Vi parlerò dei risultati preliminari che abbiamo
Talk about the preliminary results we have obtained in extradural section of filum terminale for the treatment of tethered cord syndromes in adults with Chiari and syringomyelia. The indications are for patients without spinal dystrophism with tethered cord clinical syndrome with Chiari and or syringomyelia. For the assessment of the tethered cord syndrome, we used the Chiari Institute report. Not going to dwell on that because Professor Milora has talked extensively about it. 27 cases, mean age 41 years. Period is December 2008, Salvador technique was adopted, this extradural section of the filum terminalum. This was performed microscopically, and generally the surgery time was 20 minutes, follow-up 80.3 months, 24 patients were followed in the follow-up, lost 3 patients at follow-up, no complications, no infection, and mean hospital stay 2 days. The results, the assessment was made by neurologists outside the surgical team who performed surgery through telephone interview and a clinical report. This is the report associated with the telephone interview. We asked about the degree of improvement, and then drugs, and then any worsening, what is assumed work, and going back to ordinary normal habits, and how symptoms evolve post-operatively. This is a table, the results we have obtained are such that low back pain went down in 54.5% of patients, headache went down in 51.1%, sphincteric and urogenital disorders improved in 46.1%, motor disorders improved in 41.1%, and sensitive disorders improved in 55.5%. Conclusion: the patients we operated on by dissecting the filum terminale, other patients had an improvement in over 50% of cases as far as subjective symptoms are concerned. Motor disorders improved in 42.1%, and sensitivity disorders improved in 55.5% of the cases. To validate this surgical technique, we need, of course, more patients, longer time, and a longer follow-up based also on neuroradiological studies. Thank you.
Dire qualcosa? Che se vanno così...
Do you want to make any comment? What kind of indication do you select? What is the picture, the typical picture of these patients? Adults or children? No, these are only adult patients with no spinal dystrophisms, with symptoms that can be compatible with tethered cord syndrome. So tethered cord syndrome in adults, yes, without Chiari. Well, there are 4 patients with Chiari, 1 with Chiari and syringomyelia, and 3 with syringomyelia only. It would have been nice to see some X-rays, but you said that you just started. Yes, you're right. And in the selection of patients, originally we didn't make any neuroradiological studies that shows the presence of the syrinx and the chiari, but it doesn't show the alteration of the extradural phylum terminalis. What was the outcome of the syrinx in the patients that underwent treatment? In one patient, we made MRI, and the syringomyelia remained the same, but the lumbar pain improved. We'll see.
Sono stati operati al Mayo di
Where did you operate these patients? At the Mayo in Florence and the Policlinico Scotti in Siena. Yes, but we also operated on older patients.
Grazie.
No, scusate un attimo, però sarebbe importante chiarire certi
It'd be nice to clarify some aspects because there are also some representatives, some patients, representatives from associations, and so we should shed more light on these controversial topics because, of course, we cannot, you cannot just say, well, let's wait and see. You are right, but we cannot make any further comment about the outcome because we don't have enough information about this. Well, he said it as well. We have to enroll, recruit more patients. We have to see and assess the outcome, let's say, more critically. But in any case, he talked about technical variant. I mean, when the patient has a tethered cord, we know that we have to dissect the phylum, and he does it extradurally, like Roy and Salvador does it. Yesterday we said that this extradural section is wrong. He says that it's right, and in any case he has some preliminary results that prove that it's right. Was it an occult tethered cord syndrome, or was it a tethered cord with urodynamic tests? Well, correct me if I'm wrong, you talked about patients with tethered cord syndrome, and so I expect they are not asymptomatic. They have no chiari, or one had chiari only. So the situation is quite special. It's just a technical variant. The extradural section of the phylum that I don't share, however, is something that deserves being tested or monitored. Yes, we are testing the validity of this technique. Posso chiedere al professor Milorà che cosa pensa della sezione extradurale del filo? In realtà non ho molta esperienza in questo campo, ahimè. In realtà noi facciamo una sezione diretta, ma so che molti adottano la tecnica estradurale, ma io personalmente non lo faccio, quindi non fa parte della mia esperienza. Quando abbiamo pazienti con chiari, con tronco lungo e con sindrome del midollo ancorato, noi sezioniamo il filo nel modo in cui abbiamo sempre fatto, però non ho obiezioni sicuramente. Mi chiedo solo se forse ci può essere meno precisione nell'identificazione del filo e nell'asportazione delle adesioni durali. Potrebbero esserci variabili anatomiche che io però non conosco, quindi in realtà non mi posso esprimere sull'argomento.
Good. Let's move on with Dr. Cordella, who is a neurophysiologist at the Neurological Institute. He will tell us about EMG monitoring and mapping intraoperatively during cord detethering, the experience of Istituto Besta on pediatric patients. Good afternoon. Thank you for inviting me here. In the next few slides, I will show you our experience, the experience of Istituto Besta, and Istituto Besta's approach to intraoperative monitoring during cord detethering in very young patients. As was previously said, tethering cord syndrome causes severe neurological deficits, which have already been described. One option to reduce the progression of these deficits is surgery. Like all surgical procedures, also detethering poses risks of neurological damage, and one option to reduce these risks is introducing intraoperative electromyography. We indeed introduced electromyographic monitoring, which is a continuous online assessment of functional integrity of motor pathways. We also carry out electromyographic mapping, that is functional identification and preservation of anatomically ambiguous nerve tissues. I'm going to report to you our latest experience involving 10 patients ranging from 3 months to 5 years, even though most of the patients were younger than 12 months. We aimed at monitoring muscles innervated by L4, L5, S1, and S3. We recorded spontaneous and evoked activities by using unipolar leads, both straight and hooked ones, since hooked leads prevent any contact-related issues. Since when surgery has been started, it's very difficult to reach the leads. We performed both unipolar and bipolar pacing, and we never went beyond 1 milliampere. This is what children look like before surgery is begun. This shows that we recorded activity from the quadriceps, the anterior tibialis, gastrocnemius, and other muscles. Monitoring is therefore required continuously during surgery. This is important as it enables surgeons to be more accurate and to realize how they're manipulating nervous structures during their surgical procedure. And surgeons want to recognize nervous structures before they cut other structures, and therefore we resort to unipolar and bipolar pacing. On the right, you can see how pacing produced an activation of a series of action potentials in the anterior tibialis muscle, thus providing information on the positioning of root L5 or L5 root. It's always important to pay attention to anesthesia. If the spectral index is available in adults, while a spectral index is available for adults, and electroencephalography provides more information as to the depth of anesthesia. As a conclusion, EMG has been helpful throughout the whole surgical procedure, during opening and during lipoma removal. In all 10 patients, it allowed detethering to be complete, and intraoperative EMG reduced the incidence of surgical damage to 0%. Thank you. I would like to thank the second neurosurgery department for making this possible. Any questions? During the monitoring of other cranial nerve functions, there's also spontaneous activity that gives warning signs during surgical maneuvers. There's not just after pacing. I didn't explain myself well. Monitoring helps surgeons to act and at the same time to know how close they are to a nervous structure or how close they are to a nerve root. In the mapping of cranial nerves, it's important to give feedback to surgeons, and there are intraoperative instruments that issue sounds, and based on those sounds, surgeons know what is happening at the site of a given nerve. So I mean to say that not only mapping, but also monitoring is important, meaning control of spontaneous activity. And this is also true during closure. By the way, we're talking about very young patients here. This is a technique that's used quite frequently in adults, but it's a novelty for infants. I'd like to note that we've used this method for several years, and it's very handy when we operate on lipomyelomymeningocele and there are altered structures, so it's not so easy to differentiate the phylum terminale from the root. So making sure that one will not accidentally cut a nerve root is of great help. Now, I'd like to leave the floor to Dr. Guarnera. Is he here? If he's not, never mind. Let's move on to Dr. Leva. MAR and neurosurgical issues. What are the relationships? Could you tell us what MAR is? I will tell you in a minute. Good afternoon. I would like to thank Dr. Valentin and Professor Soller for giving us the opportunity to illustrate our experience as pediatric neurosurgeons in terms of anorectal malformations and neurosurgical deformities. I'd like to outline the scenario involved when it comes to these patients. A review of the literature, which I believe we're all familiar with, shows that there are extreme differences in attitude. Some people say that surgery should be preventive, others say that surgery should be performed only when symptoms appear. So we haven't identified any homogeneous data in the literature. This is a summary of continence percentages related to various anorectal malformations ranging from rectoperineal and vesical fistulae, rectovesical prostatic fistulae, cloaca, and vesical rectum. So these are the percentages that we have available concerning spontaneous continence in children with these defects. Likewise, very well-known evidence concerning spinal disorders in these children is well known, and here are percentages related to different anorectal malformations. So what are the problems that we identify with associated with ARM? Myelodysplasia, spinal lipoma, anterosacral meningocele. This is a neurological component. At a sacral level, sacral dysraphism level, this is a list of what we usually find in our clinical practice when we deal with these patients. This is a review of our case series that we carried out to try and figure out what the population, how many these patients were within the general population, not only in Italy but also internationally. So at our anorectal malformation practice, we've followed 212 patients, and in 60 of them we identified neural dystrophism and spinal dystrophism. So we focused our attention on children in which we identified a neurological problem. And 12 of these 37 patients were operated on, whereas 25 were unoperated. So we wondered what changes were present in this population, and this is a summary of our findings. We broke down operated patients based on their anorectal malformation to try and figure out who got worse and who got better. And the key data is that as far as vesical continence is concerned, we had to resort to intermittent catheterism in both operated and non-operated patients. We still use intermittent catheterism in these children because these children are not continent, are incontinent. The main aim of surgeons who operate on these children with ARM is obtaining a clean and dry child, but some of these children were not clean and dry, so we had to resort to catheterism. In terms of continence, bowel management has been developed. With bowel management, we can turn 100% of children into continent children. Bowel management doesn't just mean giving an enema to a child, but it also means selecting the right procedure, whether it's enema, laxative, diet, to allow for regular bowel movements in these patients. So we analyzed our 37 patients, and we can say that 37 of them are clean, which is our objective. So our objective has been fulfilled. But out of these 37 patients, 4 had to undergo intermittent catheterism. Of these 4, 2 had a rectovesical fistula. And if you remember the previous slide, 0% of children can be continent with this type of anorectal malformation, and 2 in 7 patients resort to intermittent catheterism, start following cloaca. That is 23% of our population, which is the same percentage that we find in patients who do not have any neurological problems. So conclusions based on our experience and a review of the literature are that we were unable to find good evidence that the presence of neurological disorders worsens the functional prognosis of patients with anorectal malformations. We were also unable to find convincing evidence to support the practice of prophylactic neurosurgical procedures. This statement is also supported by our own data, because in our patients as well, we have seen that neurosurgical treatment didn't modify the effect on the continence of these patients. As I previously maintained, we believe that a correct management of patients with anorectal malformations should include a range of investigations to rule out the presence of a neurological disorder, a neurological malformation, or a spinal malformation. And once this malformation has been recognized, it is advisable to manage these patients according to a multidisciplinary approach whereby a pediatric surgeon, a neurosurgeon, a urologist, and a gynecologist cooperate in the follow-up of these patients, because we, as pediatric surgeons, do not have any answers concerning neurological disorders. We can only have a say in terms of continence problems related to anorectal malformations, and therefore a multidisciplinary approach in these patients can make the management of these children adequate and successful, because the power of teamwork is the winning power. Thank you.
Team dell'Inter, quello che vince.
Io parlo di
That was Milan International. I just wanted to highlight teamwork, not the color of the team. Any questions? Good. Now it's the turn of Dr. Caradante from Naples, who will hold a presentation on Chiari 1 malformation with associated syringomyelia.
Complimenti agli organizzatori e grazie per l'invito.
Thank you very much for the kind invitation.
Nella malformazione di Chiari 1 abbiamo ampiamente
In Chiari 1 malformation, we have seen that cerebellar tonsils are dislocated in the upper cervical canal at the first level of the C1 and C2. Chiari 1 is associated with the syringomyelia in 30% of the cases. The malformation can be asymptomatic and can be incidentally found, and when it's symptomatic, it has signs and symptoms that we have debated upon extensively. The method of election is of choice is magnetic resonance to assess the degree of dislocation, and the syringomyelia, we see magnetic resonance in a Chiari 1 case. Here we have a cervical dorsal syringomyelia. Once again, Chiari 1 and syringomyelia at C2. This is an horizontal view. Chiari 1 associated with a massive cervical syringomyelia. Same case from another view. Vast majority of the cases, the disease develops slowly and progressively. In 10% of patients, the syndrome has an abrupt onset. These patients are kept under observation at our hospital, and every 6 months we carry out a clinical and a neuroradiological examination. Only 10% of Chiari 1 patients have a worsening of the symptoms requiring surgery. Patients with clinical worsening picture with no response to medical treatment and with difficulty in their working life are candidates for surgery. In 48 patients affected by Chiari 1 and syringomyelia, only 5 were treated surgically in the last 10 years. Surgical treatment consists in suboccipital decompression, removal of the posterior arch of the atlas. We see the excision, the removal of the C1 arch, the atlanto-suboccipital craniectomy, the Y incision on the dura, and in these patients, since these are all adult patients and with worsening neurological picture, we have always freed up the PCAP from the arachnoidal branches, and here we see the opening of the arachnoid. We have the exposure of the cerebellar tonsils and of the plica, and we dissect and empty the tonsils, and during the procedure in particular we always try to protect as much as we can the peritonsillar pia, because once tonsils are emptied, they are coagulated to the dura with a stitch, with a suture. and then we do the duroplasty with a synthetic patch. Here we see the volumetric shrinkage of tonsils through coagulation, partially coagulated tonsils. Craniectomy and dural graft must be limited to avoid the onset of pseudomeningocele. The closure of the dura must be accurate so as to avoid CSF fistulae. This is a post-op CT image showing the craniectomy, which is rather limited, and then magnetic resonance post-operatively, where we see some occipital craniectomy. We see also the removal of the posterior arch of C1, and we see the cisterna magna that is well visible. All patients have become stable and symptoms have improved, thus enabling them to lead an ordinary life, an ordinary working life. Of course, these patients are highly symptomatic. In the 5 patients we treated with this technique, we also had a good control of disorders associated with syringomyelia, and no patient has required a surgical treatment for a syringomyelia. Thank you.
Domande?
Questions? I'd like to ask you something about this epidemiological piece of data, so this referring to the symptoms. Only 10% is symptomatic. Well, I see many patients with Chiari-1 associated with syringomyelia, and many of them are symptom-free. And I have seen many, but only 5 required surgery. And this turned out to be the most effective approach because we had good clinical results, and so this is the approach we have adopted and will adopt. So let's close this very interesting day. We'll see you later at 8 o'clock. There is going to be an aperitif, our